So let's just wait. We are live now. We are live now on YouTube. And let's just wait 30 seconds before we go and start talking. I think Azuka will join us. Okay, good afternoon, everybody. We're now live on YouTube, and this is another episode of the African Catalyst, one on African Catalysts post-COVID-19 discussion series, where we discuss a number of issues related to the post-COVID issues and the issues we believe are pertinent for stakeholders, to move forward, to basically drive their business going forward. I have a number of people here in my panel. I have Mr. David Baxter, I have Mr. Kolaoni, we have Ezine Ayang, and myself, and there's also Azuka who's going to join us soon on this. Regarding this, I'll just basically introduce everybody to our I'll basically just introduce everybody to our view on what exactly African Catalyst is all about. African Catalyst basically is a platform which is sponsored by Brickstone, basically used to unlock Africa's growth potentials and discuss a number of things in Africa that has to do with opportunities in infrastructure and industries, and also in other consumer life products. Moving on, you could get more information in the africancatalyst.com. You can always click there to find more information about us in itself. Now, why post-COVID-19 discussion series? I had discussed this, with a number of, we've had like two previous episodes. One episode discussed issues related to supply chain issues in Africa. Another one discussed on issues related to what's called now contractual performance. What's important for us at this point, basically, is to find a way we can use these live stream opportunities to sort of like give us a clear overview of where the market or the businesses will be positioned on a post-COVID-19 era in itself. And I have here Azuka also joining us now. And now we're going to be talking about the immediate and long-term impact of Africa's healthcare systems. One of the key important things we ought to know right now is that in Africa, yes, there's been a dearth of infrastructure, a dearth of healthcare, hospitals, and the number of intermediaries that is required in the healthcare system that have not been provided. We are now on a double demand base, whereby there is need to provide ongoing healthcare for mothers, pregnant women, children with pediatrics and things. And there's also the challenge of providing healthcare for pandemics and diseases such as COVID-19. We had episodes of Ebola about 3 or 4 years ago. We tried our best, but I don't think we learned from it. And now we're having this COVID-19. And so this discussion series is basically this episode is basically going to take us through what we think will be the critical issues in itself. So I will just go over each of my panelists, and they will basically introduce themselves. And after the introduction, they will just let us know what they're doing now. And then we will now start taking, the questions in itself. I'll start from Mr. David. I'll move to Kola and Ezine and also Azuka. Azuka, welcome on stream. Thank you.
Hi, my name is David Baxter. I'm originally from Cape Town, South Africa. Spent a large percentage of my professional career working in Africa, in many African countries, West Africa, Southern Africa, East Africa, and even in the MENA North Africa region, where I have focused on helping governments build capacity to implement PPPs, And I've worked with the World Bank, USAID, and multiple different aid agencies. And a little later on, I will address some of the challenges and opportunities that COVID-19 has created for PPP healthcare infrastructure in Africa.
Okay, Kola. Oh, your mic. Okay, go ahead.
Okay. Good afternoon, everyone. My name is Kola Oni. I have a background in finance. I've worked with two of the big four firms, primarily started as an auditor, but over the past 10 years, I've focused more on corporate finance and helping foreign companies enter the Nigerian market. More specifically, over the past 5 years, I've been actively involved in raising healthcare financing for hospital projects in Lagos and Nigeria. Over the past 1 year, I've become more actively involved in actually running and managing hospitals from an operational and finance point of view, not clinical, because I'm not a doctor. So these are some of the insights I'm going to share in the course of this live stream today.
Thank you. So Ezine, over to you.
Thanks so much. Welcome, everyone. My name is Ezine Anyanwu, and I am the founder and CEO for Efferent Services Limited. Efferent is a health technology firm and focus on enabling communication between doctors, patients, and machines. And our core focus has been on telemedicine for the last 5 years and currently more on teleradiology. And so we're very passionate about using technology to improve and transform the way healthcare is delivered across Africa.
All right, thank you. And Azuka?
Thank you.
First of all, thank you for having me on this panel. Good afternoon, everyone. I'm Azuka. I'm a regional director for Africa Resource Center for supply chain. It's a Bill and Melinda Gates initiative, and our core mandate is to advise governments to prioritize supply chain management as an enabler for primary or for healthcare delivery. So my role is to be a thought partner to government to increase investment from the government angle, and also to advise donors on how they spend for supply chain.
All right then. Thank you, everybody. So our listeners can add their questions in the chat box on the YouTube live stream. We'll take some questions at the end of this. Now we'll just start with the key points of the discussion, and we'll start with the first point. Basically, is how finance and clinical leaders in Africa can collaborate to drive down costs, improve liquidity, and encourage movement towards care models that can handle pandemic situations in Africa. And I think Azuka will just share light with us on this, and we will also have other people, contribute, in itself. Over to you, Azuka.
Okay, thank you very much. So, I mean, the issue of financing and also collaboration is very, very, dear to my heart, because, and also financing from the government angle. So the question here is what are we looking at in terms of financing for health, and how are we going to foster collaboration between the finance and the clinical leaders across Africa? That means already we all know what is going on with COVID and how this is impacting everything that has to do with healthcare. Number one, so I'm going to look at three key things here. Number one is, how are we financing health in Africa? And then we talk about during this whole pandemic, how do we typically finance health in Africa? The other thing we look at is what kind of what policy frameworks exist in Africa? What strategies exist to leverage on finance? The third thing we look at is, what capacity do we have as a continent? Even if we have the financing, we have the strategies, do we have the infrastructure to make health accessible to people. So now, if we talk about what is the existing structure for financing for health, using Nigeria as a typical example, I think 2 years ago, we looked at the budget for health under the Federal Ministry of Health. And of all the national budget planning, we only had like 8% for health, 8% of our budget for health. And when we looked at that, we said, why is it that we have such a beautiful health system? Look, like we have something that is happening in Africa, not just in Nigeria, where we have a system that is very, very strong on donor investment. That is, we are leveraging or we're dependent on donor investment, the donor investment space. We have so much money coming in from different, whether it's USA, PEPFAR, whether it's Bill and Melinda Gates, whether it's Global Fund, Gavi, funds coming in that it has made our government relax their part in investing for health. And we must understand that these donor funds are not coming to strengthen the system. They are there to strengthen donor consent, so to say. And in doing that, they've created a lot of parallel systems in the country. We normally call it even a spaghetti public health system. Everybody is coming in, bringing in their own infrastructure, bringing in their own supply chains. So creating a lot of, I don't want to use confusion because yes, a lot of good come from it. We have so many lives saved for things like HIV/AIDS and malaria. However, what this has done is government has not been typically funding health. In Africa as a whole, we have 80% of Africans rely on public health facilities. 80%. In Nigeria, 60% of Nigerians use private sector. So you see the challenge we are facing in Nigeria with COVID, for instance, where we're all locked in. We all have to access our health facilities. Nobody is going anywhere. And how are those health facilities? Now, I mean, let's even leave the financing. The second thing we're dealing with in terms of where we are and what we've seen for ourselves is strategy. Do we even, when we talk about collaboration, I've done a lot of PPPs. One thing is clear, no private sector, no financial investment system will support a system that does not have an articulate model. If you don't have a clear strategy riding on an existing policy, it's very difficult for anyone to fund that system. Prior to this, we find that if a healthcare facility, I'm happy that Kola is here. If a healthcare facility wants to get loans or wants to access financing system, you are talking about double digits interest rate. You know, how many healthcare facilities can afford that kind of loan? So you see a lot of people don't actually typically invest in infrastructure because there are no government subsidies. But we're happy to see CBN with COVID, there is a 100 billion naira credit facility for COVID responsiveness. And that 100 billion naira, they said it's for infrastructure, it's for healthcare facilities, and is a single digit 5% interest rate. Then we see it's for pharmaceutical industries to access that. However, that goes back to, do we have policy frameworks? Do we have government that has strategies for emergency situation? Which was why Lagos State, when they came to me, they said, we need a strategy for emergency supply chain system. We need to be responsive. Prior to this, there was nothing. So we're being a reactive government. You can't start developing strategy when you're in the outbreak, because your priority at the moment is to treat, to take care. So that's the challenge. Even at the national, 2 years ago, just to be very practical about what we're seeing, 2 years ago, I had approached national government and that is a national, I would say, a partner that is affiliated to NCDC. I said, you need to talk to NCDC about having a humanitarian logistics system. A humanitarian is similar to what you see in Red Cross, World Food Program, because they are able to respond to outbreaks. I said, because I don't want what happened to Ebola. Ebola we were able to contain. What would happen? Just like Bill Gates, like you said.
Yeah.
I mean, what would happen if we have an outbreak? And I was willing to help them. I said, you need to have a system that is more responsive and proactive. But at that point, NCDC didn't see this. And so they were not willing to create a strategy or a framework. Now, even if CBN has brought out this 100 billion naira for access, you have to have a clear framework. You have to have a clear strategy to access that credit facility. If you don't have it, it will be difficult for anyone to give you funds. Right now, we are also seeing so many private sector funds coming in. If you watch you see Aliko Dangote, several banks are bringing in money. So there is money. In Lagos, we had to even create more warehouses. Now, they are donated commodities. Who gets it? Are we even getting what we need? I mean, ideally, if we had a framework or a strategy, what we would have said is, everyone, if you want to give us money, use it to buy test kits, use it to buy PPE. But we see people giving us insecticides. We see people giving us cars. We see people giving us equipment that, yes. So without a clear strategy, the collaboration cannot work. So I think the key takeaway here is there are financing mechanisms in place now to support the COVID response from the CBN, and we have so much donation from individuals, banks giving. I mean, this is cash that's sending through an account in Nigeria. However, we don't have the strategic framework to rightly take on some of these things. There are issues about the risks, who is coordinating, do we have visibility? Those things are challenges that we are seeing, and post-COVID, we have to do something about that. So I will stop here now.
Thank you so much. Thank you so much. Yeah, just to add to yours, I mean, one of the things which I also wanted to point out, which maybe the question might not be pointing out, is in regards to payer models. So everybody who goes for healthcare in Nigeria is meant to have this Nigerian international insurance scheme, but we all have our private healthcare schemes. So before I go to caller, one of the things which every financier always wants to see is, who are the payers? What kind of model do we have for the payers? So in Africa, I see a situation where we'll start having a more organized form of payers, in terms of either you pay your health taxes or some means whereby you have health insurance. It might be compulsory, but even if it is 1,000 naira that everybody in Nigeria or everybody in Africa can afford, that's like that's less than $5, or yes, about $5, or let's even say $10. You know, let's say $10. It will go a long way in helping the healthcare industry to plan properly, you know, to use the things. And I thank you for what you mentioned also, because like all these monies that are coming together now, I was thinking that part of it should also be used to putting some foundational things together. Yes, they might spend everything on COVID now in terms of getting test kits, getting this, but let them also think about the future. You know, there are hospitals that are being run down. You know, maybe they just need 500 million to do a proper upkeep and co. So I'll go on to the next question, which talks about labor-related shortages, interruptions, and quarantine measures limiting the healthcare systems in Africa, especially in the post-COVID era. Because here, Kola is just going to share with us that what his own views are and what he's doing and his own firm, and on what areas he thinks we can use to limit this impact of shortages we see. Over to you, Kola. Your mic.
Okay, very good. Thanks a lot, Femi, for that background. And picking it really from where Azuka stopped, Africa, even Nigeria specifically at the moment, one of our biggest problems is that we do not have a healthcare ecosystem. the ecosystem goes beyond just building hospitals or goes beyond just the financing. It includes the payment system, how we receive payment for medical care. And we're going to talk about that a little bit. It also includes the supply chain. Where do we get our consumables from? Where do we get a lot of the things that we use in delivering medical care to the populace? Our talent pipeline then includes our infrastructure and, of course, the overriding framework, the regulations, and the laws that are governing healthcare. We were better than this a number of decades ago. There was a time when specifically the university, the University College Hospital, UCH in Ibadan, was like a center of excellence in the Commonwealth. But things broke down as different parts of this ecosystem collapsed. And it was one of the reasons why medical talent fled Nigeria, fled Africa as a whole. And if you go to some of the most developed countries in the West today, they have huge number of doctors from Nigeria who are busy trying to make their healthcare system much better. While actually in Nigeria and in large parts of Africa, we still have a lot of problems. Now, these medical exports that we have actually sent out into the world, occasionally, they do come back to Nigeria and other parts of Africa through two critical means. One of them is medical missions, and the other one is expensive specialist importation. Medical missions are mostly humanitarian, when you see a group of doctors gather themselves together and come over to the continent or to Nigeria to provide free medical care through certain outreaches and things like that. Then we have certain specialist organizations that are being set up specifically to provide high-end, expensive medical care for specific type of conditions. You understand, when you have patients who do not want to fly out of the country, whether because they're old or otherwise. In a post-COVID world, we think this is really going to be impacted. We think a lot of the disruptions to transportation, the risks about transmission of infection and other things is going to make it much more difficult for these sort of talents to come into the country or to come into the continent. So we see a situation whereby telemedicine is going to become far more important. A lot of times there are certain trends that will change because events like this pandemic will force change in habits, and those habits will then become sustained and there will not be a reversal. We think telemedicine is going to be one of them. If you look at all of the major hospitals in Lagos, they have rolled out telemedicine over the past 2 weeks. One of the hospitals where I'm closely involved with, within the next 1 week, they need to roll out telemedicine. Of course, we know that there are questions around the way telemedicine itself is being rolled out in the country. Is telemedicine meant to be rolled out as something that is embedded into hospitals, whereby you basically just have a white labeled product and you sell that product to different hospitals who then embed it into their own system? Or do you want to set up telemedicine as a competitor with a different brand name to existing hospitals, and then you have your own doctors? There are questions about what model is going to be sustainable in the long run, but definitely what we know is that telemedicine is now back and it's here to stay. One other way that we think a change can happen is in terms of some sort of medical diaspora fund. We think it may be possible for the international community to come up with a medical diaspora fund, whereby if you see Africans, Nigerians who are very experienced and who have achieved a lot in the medical field and they are ready to come back to the country, but maybe by reasons of the inability of the existing players in the system to match their pay, we think we may need some sort of a global fund that can be used to give people some minimum amount of payment as long as they commit to spending maybe about 250 days a year in the country. Then whatever salaries that the the local hospitals is able to give to them just becomes like a top up, over this amount. That would be a very sustainable way of actually bringing in some sort of medical talent into the country and into the continent. It's something we believe that we may want to look at. And then we eventually, this is also going to lead to a change in the supply pipeline for medical talent in the country and in the continent, right from nursing all the way to the highest level of. One of the things that we found out in this COVID-19 pandemic is that we've been talking about ventilators and quite a lot of other things. But unfortunately, even if you have a ventilator, you need an intensivist. You need people who are specially well trained, be able to manage the ventilator. And unfortunately for the country, the few well trained ones who have come back are actually not in the public sector. So all of the billionaires have ended up providing tents and isolation centers, but you don't have the medical personnel to manage those critical cases. And those critical cases are realizing that they still have to go to the private hospitals to receive care. So when you ultimately, we think that there will be a massive push to really find a way to start developing more talent locally. We have talent at the moment, but more find a way to retain such talent. And that's exactly what Healthcare, for instance, is trying to do. We are trying to create large healthcare organizations. At the moment, a lot of healthcare organizations in Nigeria specifically are more or less mom and pop shops with 5-10 bed facilities. It's very difficult for you to attract established medical professionals if you do not have organizations that are this big, that can also make things work. The second part of this has to do with transport interruptions, which you also mentioned. The transport interruptions that we're going to experience in the post-COVID world are going to be real. There will be more tests. There will be more delays. There will be lots of times that people will be turned back at the airport. Even cargo deliveries would also be impacted very, very clearly. So one clear area is that we need to be smarter about the way we manage inventory, whether it's consumables inventory or drugs, inventory. You need to know how to place your orders. You need to know when to place them. You need to know the right amounts to place and all that. So organizations will need to become much smarter about how they manage inventory. One other thing that is going to change is that the current supply chain is very, very linear. The world has really become complacent. I was reading a report recently that 80% of a lot of the rubber-based medical consumables are actually manufactured in Malaysia. Especially the gloves that are used, simply because of the cheaper economies of scale that comes to the fact that Malaysia produces a lot of rubber. A lot of these models are being challenged because from a purely risk management point of view, the world will probably not want everything to come from China alone anymore. So with the supply chain for medical items and consumables is going to become more diversified, and a lot of complexity will then be introduced into it. That means we need to be much more intelligent and smarter about the way we manage inventory, about the way we manage, so that we can anticipate disruptions and things like that. Of course, this will probably lead to more quality because you now want to probably have much more global standards that you need people to work with. We think that will work. And we also think that there will be a lot more innovations locally now. As the supply chain globally becomes more complex, countries will be forced to look inwards more and more. There are lots of companies that are now trying to manufacture syringes and so many other basic things, in the country. We think this move, the increased cost associated with the global supply chain, will definitely make these things, would accelerate some of these trends. And these are really the things that we think.
All right then. Thank you so much, Kola, for the great insight. I think one of the things you clearly shared was the fact that and there's going to be debt in human capital. We need to develop capacity, and also issues on disruption. And over now to Ezine to give us our own views of how we can use maybe other technological advancements in a post-COVID era, or the trends, which she thinks, and she's also involved in that sector, and that we believe can be of use to help the healthcare systems. Over to you, Ezine. Can you hear me?
Yes, okay. Thank you so much. I hope everybody can hear me. Welcome. So I would say COVID-19 has made a very strong case for the need to implement technology in healthcare. We know that, as Kola mentioned, telemedicine is simply being able to deliver health services using technology. And healthcare has, not just in Africa, but across the world, has been the last sector to really adopt technology, being surpassed by agriculture. You have various types of innovations and digitization and automation in agriculture, but healthcare continues to lag behind. And we find that, with healthcare, we understand that it's a very personal doctor-patient relationships, is a touch, is a feel, but COVID has now shown us it's either you evolve or you die. We are in the fourth industrial revolution, or heading into the fourth industrial revolution, that's technology. And so from the Africa perspective, there's actually, COVID has also made a case for, while Africa is still lacking the barest of the barest and basic health infrastructure, it is a time to really add technology involvement and development as part of growing this healthcare system across Africa. And one of the interesting things is that we all know, everyone, is that Africa's problems requires Africa's solutions. Transplantation of technology from a developed world to Africa rarely works. And healthcare, I have lived it for the past 5 years, it definitely doesn't work. But the opportunity that COVID has really shown is Africa can actually leapfrog in healthcare, just as it did for mobile technology and financial services. And so from us, we're post-COVID, that Kola had mentioned, I'm very, very optimistic that technology like telemedicine will continue to actually play a much more pivotal role than it has before. Many of the interactions that would require traveling currently will no longer really be happening, because, again, transport is really going to be impacted. And so for just give a bit of what we're doing here for Efferent, we have actually deployed over 12 different telemedicine platforms, and we have continuously learned that localization is going to be very key. And also, more people are going to be open to having discussions around technology. It's making a case for a lot of different health tech startups as well, because there's going to be a need to really have sort of a localized workflow, but it also poses a clear opportunity around standardization of care. As we're building basic infrastructures in healthcare, it is a time to start standardizing healthcare, standardizing protocols, standardizing quality of care. And this is where technology could really play a pivotal role once we can look at that post-COVID, because there's going to be a lot of data.
Oh wow! I think we lost her there. Maybe she'll soon join back. And I think what she was just trying to talk about was basically on the data that will be gathered, on a post-COVID basis, and a number of. Okay, she's back. Okay, yeah, you can go ahead. Yeah, Ezine, you can go ahead.
Oh, thank you. Apologies for that. This is the world we live in now. And so, as I was mentioning, as we are looking at post-COVID, there's going to be a lot of data requirements. This is, again, where we're going to see technology playing a very, very pivotal role. And with that said, we really have to start looking at the people, the process, before we start looking at technology, because, again, we know that there's an opportunity to standardize, and also from a regulatory and policy perspective, we can leverage technology to ensure, monitor, and enforce quality and safety in healthcare. If we don't do that post-COVID, we're going to be missing a huge opportunity to really drive quality and safety across Africa. And so for technology, some of the trends we're going to be seeing, I think first we're going to be seeing a lot more interest, adoption, which was not already or previously because we were living it. And we're also going to be seeing some of those tailor-made solutions, which would allow for standardization. And at Friends, what we're doing, we have always done teleradiology. So teleradiology is being able to send your scans from your X-rays, CT scans, MRIs to any doctor anywhere in the world. And we've been able to transmit over 60,000 images. What we're looking at now is being able to have to launch a platform that would allow doctors to be able to see more patients regardless of their location. And this is what we've been speaking to many of the doctors now that normally would not want to have these kinds of conversations, but they don't have a choice. We're in a lockdown. So we're seeing more interest and adoption. So I think doctors, various players in the health would be willing to come to the table and have those discussions with technology being a foundation for what they're trying to achieve, rather than sort of there's a bit of a resistance that there's high infrastructure costs to implement good health technology. There's lack of users. I believe we're going to be seeing a lot more patients with technology in healthcare, and technology being a big topic as we're looking at developing healthcare infrastructure post-COVID. And I would say we're also going to be seeing a lot more funding going towards health technology post-COVID as well.
Correct. Thank you. Yes, that's very, very interesting and it's very key because especially in the area of telemedicine that you mentioned, I think it's also an important thing. But on behind of telemedicine is the bandwidth, the internet. Just as we are talking today, we have so much of internet we need to pull these things through. So I will just go over to David, and this is really where we can see how private-public partnerships can play a role in getting these healthcare systems developed, whereby whether it is hospitals, whether it is pharmaceuticals, whether it's diagnosis, whether it's telemedicine and things. And he will be able to share his own experience on how he's used PPP, to solve in other sectors like education that has been successful all over the world. We now have, a lot of private-public partnership in education, but healthcare in Africa has not been able to enjoy that level of, synergy. Over to you, David.
Thank you, Femi. Last Sunday, there was an interesting article that appeared in the New York Times, and the title was, "Some nations need just not more ventilators, but they also need soap and water." And basically what this was an article about was about Africa, where they were saying, we've got so panicky and focused on high levels of technology and that, but we also are ignoring innovation and opportunities that the private sector can bring to the table to help build the building blocks that will improve the way we combat COVID-19, not just now in the short term, but in the medium and the long term. It was rather sad when I read that for the whole of Africa, there are approximately 2,000 ventilators available, while for the rest in the United States, for example, which is having a horrendous time if you follow the news, there's 170,000 of them. And, there's a terrible disconnect. But the big point is that they said, that we need to have a strategy. And this is what a number of the previous speakers, Zeni and Azuka, as well as Kola, mentioned, that there's a need for a strategy. And unfortunately, for some weird reason, which we'll never understand, many of the institutions, trans-African or pan-African institutions that have been established, haven't been able to kickstart this. For the Africans, the African CDC, for example, has launched a number of programs, but it really hasn't come up with data. In the 1980s, the World Health Organization launched the Health for All initiative. And Africa embraced it, but this was in the 1980s, but we still got stuck because things weren't happening. What was interesting was that the article also pointed out great innovations that the private sector on its own is introducing because they're not waiting for the public sector to come up with solutions. And one was an example of a hospital in Mekelle in Ethiopia, where they ran out of oxygen and the oxygen generating plant collapsed. But interestingly enough, the private sector right next to them was a big denim factory. And I didn't know this, but it's interesting that to produce denim, when you have to bleach it, you have to produce lots of oxygen for the chemicals that you can use to bleach the cloth. And this factory had excess oxygen production. So what
they were just next door. Wow.
People got together and said, well, you say you don't have oxygen, we have more than we can use. Yeah, let's form a relationship. So that I thought was just an interesting perspective on, what things can do, of training people, etc. The IFC a number of years ago said the following: that government's ability to provide affordable quality health care dwindles every year. The challenge is now to engage the private sector to deliver public benefits, innovation, forward-looking public-private partnerships in healthcare, and keep the business moving forward. And, this is, I think, where PPPs come to the table as a source of innovation. Let's be honest, bureaucrats are not paid to be innovative. They are paid to follow the guidelines. And if the guidelines are poor or the practices are poor, they're going to give poor service. And I apologize to all the public servants out there. But But you're doing a good job in difficult circumstances, but why not reach out to the private sector, which is the source of all innovation? Now, the question we might ask ourselves is, what do we mean by PPPs? The problem is there are a lot of crazy, wild definitions out there. There's a spectrum of definition of PPPs, some which are really just partnerships between the public and private sector, which previous speakers have spoken about, which are sort of philanthropic approaches, approaches introduced by the aid agencies, etc., where they will give money for a very focused something or event or a need, often which addresses their strategic interests or their NGO interests or whatever, but it doesn't look wider and broader. Now, we need those because they fill in the gaps, because philanthropy does help, but this is not a sustainable type of PPP, because when the what you call the sponsor of the NGO or the corporation, which has a guilt feeling and introduces corporate social responsibility, when they get tired of that, the flavor of the day is gone and they move on and these initiatives collapse. What we should be looking towards are what I would call more formal public-private partnerships, which, and I'll give a general definition, is where the public and the private sector enter into a formal agreement to collaborate over a period of years, which in many cases can be 20, 30, 40 years, to provide a service and innovation, and this is important, where risk is allocated to the appropriate parties that can handle the challenges the best, and where good performance is incentivized by payment. Okay, there's a lot that I've said there, but what you're saying is, use the private sector, and if they perform well and you can form these lasting partnerships, let them get some financial reward out of it. But it's better to pay a little bit more maybe, or to pay a bit and have something that works and have something that's dysfunctional or just has a very short timeline. It is important that we look at the multifaceted elements in PPPs. And Akola, you talked about this. It's about talking about how do we protect the supply chains through PPPs. That is one element that needs to be considered, is how do we protect the services, the training. I think Zina and Azuka, you both talked about that. The training, capacity building of healthcare workers can take place through public-private partnerships as well. But then there's the big element as well, is how do we provide or prepare the infrastructure which is necessary? And here we're talking about hospitals, sanitation centers, even ancillary ones like power generation. A hospital is useless if there's no power. Water, if there's no clean water, it is useless. So what we need to do is have strategies, because if there's no strategy, everyone's running around. I don't know if you've ever tried, if you've gone into a chicken pen and you try and catch chickens, they all run in different directions and you're just exhausted.
Yeah, exactly.
You can't have this situation like this, especially if you have a knife in your hand and they know that somebody's going to be sacrificed for dinner, they run even faster. So we need to move away from that and start looking at strategies. And what I suggest is that, we need to look at 3 levels and the short-term strategies. And I think these are the strategies for the next 0 to 12 months. So from now till the end of the year, or 12 months from now by then, which they say COVID is going to be decreasing. And that is encourage philanthropic agreements, because these are short-term ones. Go to the Bill Gates of the world and different foundations, the Rockefeller Foundation, and say, we have an emergency. Can you help us get this now? Improve the supply chains. Improve access. One thing that's important, as was mentioned, is digital infrastructure. Start improving the digital infrastructure so you can do telemedicine. But what is important during the short-term strategy is identifying the gaps so that you can start moving towards a medium-term and a long-term strategy. Now, when I talk about medium-term, I'm talking about 1 to 5 year type partnerships. And this is where you are looking at supply chains, forming partnerships, so where you can ramp up the production of the minimal basic things, just PPEs, the protective things. Focus on that so that doctors don't die, that patients don't die, that it doesn't spread. That is, to me, a 1 to 5 year strategy. And I think what is important at national level, there needs to be a refocusing on 1 to 5 year programs where you look at the production of the simplest of healthcare quality, healthcare equipment, masks, surgical things, screens, you can name it, gloves. A lot of that doesn't take high-level technology. I mean, my wife and I, we sewed our own face masks because we couldn't get them. Governments can focus on as simple as that. You don't have to import all this stuff from China, Malaysia, or whatever. You don't need to have monopolies where it is controlled. And one of the biggest challenges is governments will need to start preparing low-key production, because the biggest fights that we're seeing are not over high-tech, but low-tech stuff, and their countries are competing against one another. And when they compete, the prices have been going up to ridiculous levels. There's situations where surgical masks would cost 50 US cents normally, and now they're selling for $5 because there's competition. So I think in the medium term, look at proactive PPP projects and strategies that are pragmatic. And in the 5 years also, this is a chance to create legislative enabling environments that encourage the proliferation, let's call it, of healthcare PPP programs. Because unless governments change the laws and the practices, we are going to have a situation that no matter what the private sector does, it's going to be blocked by unnecessary red tape, and they're not going to be able to move forward. Finally, and I don't want to take everyone's time, but the long-term strategy, and this is where you get to the big PPP infrastructure, the hospitals, the clinics, the testing labs, and that. And these are PPPs that can be, as I said earlier on, +5, 20 years in duration. Here you need to work with organizations nationally. So for example, like in a country like South Africa or Nigeria, where they essentially have a federal system where all the different states or provinces are competing against one another. They need to harmonize their efforts. I would think it would be really important is to, at least in each state or province of a large country, to consider through a PPP program, at least having one center of excellence for healthcare in each province or state. And this needs to be harmonized with the national priorities and national pipeline and national strategy. You don't need to have all these big healthcare systems in the capital cities. That's where they always are. And that means that 90% of the people can't get to them. And then as you evolve and you start working, there should be opportunities for regional collaboration. I know, for example, ECOWAS in West Africa has a very strong regional program to try and promote harmonized and calibrated and coordinated healthcare. This is a long-term type situation. I think you should also reach out to the big industries, the oil production industry, the power generation industry. it's critical to form public-private partnerships with them, where you could put a hospital in a big oil refinery that serves the healthcare of the workers in the oil refinery, but it could also serve the purpose of the healthcare of the surrounding communities. So think big, think bigger pictures. And then as you work from your national level to your regional level, then you can start reaching out, as everyone's calmed down, internationally for international collaborations with the World Health Organization. There's so many organizations out there. I think there must be hundreds. But these organizations also need to coordinate their efforts. And one thing that I do want to point out, and then I'll end at that with PPPs, is one of the speakers, I can't remember who said that, they're talking about the technology, the level of technology. Africa is full of technology, but unfortunately, a lot of it has become obsolescent because it's not being kept up. Private sector can help with that, but what is important is an African need or an African level or an African approach to technology, because you have to ask yourself, do I need version 10 of a ventilator that's got bells and whistles that just, work? Or would a version 5, which costs half of the price and does the same job as well and requires less trained people to run it, do it? So, these are sort of the production capacities there to be considered. But I'm a firm believer that the public and private sector must collaborate, because it's obvious that the public sector does not have the capacity, and it never will. And yet,
thank you so
I'll end there.
Correct. Thank you very much for your very, very well articulated talk on it. And it's really important. I mean, a number of things you've mentioned are things that a number of people are listening to, both in government sector, the private-public partnerships are very key. And as you mentioned, I mean, the face masks and the gloves, why can't we produce them locally? Why can't we have the funds we are gathering to set up a face mask factory? And because a number of countries now are trying to lift the ban, and they're basically also saying that, okay, if they lift the ban, they will still require everybody to wear face masks, post-COVID and things. And where are they to buy? So I think it's a very important point you've mentioned, David. And I think, government should actually provide a tax holiday, free waiver for anyone who wants to set up, a PPE equipment factory for healthcare workers. Then one of the things I think I would like us to discuss, starting from Azuka and every other person can chip in, is the payment system. The fact is that because we don't have a apart from South Africa, I don't know any African country that has a national health insurance scheme that is compulsory for everybody, because that is the foundation of any investor. I mean, I've looked at that. I can see the cash flow coming in. So if you have the way you have in the UK, I don't have so much information about the NHS trust, but I know the NHS trust gets taxes from almost everybody in the UK wherever they are. And looking at private-public partnership that David mentioned, especially in the hospital, in the care space, hospital and diagnosis, if Africans don't have the right jobs, if they don't have the right enablement to pay for their healthcare needs, right? Are we saying that government will now become another subsidy? Are we saying healthcare is going to be a subsidy? I don't think so, because most African governments now want to go away from subsidy. But in the area of the payer system, that's the word, the payer system, what is happening in African countries, and what do you think are the solutions?
Femi, I could add one thing.
Okay, go ahead.
We've looked at these pay systems, but there's another source of financing to bridge the funding gap between what governments can deliver and what they are doing, and that are pension schemes in countries. Africa is sitting on trillions of dollars of underutilized pension payments that are going into pension funds that are just sitting there, because many cases these pension funds are required to invest their funds in their country. They can't invest it overseas, but they have places to invest it. And if they
It's true.
invested it into a well-structured, how would you call it, healthcare system, a well-structured policy, a strategy, even if they start at low level, just, you know, the PPE production, of goods, they will get a return, and it will be good utilization of enormous amounts of money that are just sitting dormant at the moment.
Okay, you're right. That is good for funding the infrastructure. The part I'm more concerned about is the patients paying for that service. And I think that is for the patient to make that payment, you know. So I want to say something.
Yeah. Okay. I think if you're talking about Africa and what is existing, I'll talk about two systems in Kenya and in Nigeria, what is existing in terms of the insurance. Kenya has somewhat set up an insurance scheme that is very private sector driven, very technology driven. That's where you talk about the investor. Now, it is also a system that, you know, they have leveraged technology because they need, you know, with any scheme, you need visibility, you need data. You need to have a way to capture the right people that can access care and then be able to define what, you know, whether you are going to assess capitated fees or whether you are going to get some free services. Kenya has something in place. It's something that they have that has been strengthened by a donor system from the Netherlands, but it's something that is in progress and can be leveraged. And it's something that government commitment, which is something that post-COVID, I see that, as Ines said, there will be some changes, because if you don't change, it's going to happen again, and you're going to get the care that you have put in place. So there is something happening in Kenya. It's private sector really strong. It's technology driven. It's something that Kenya can strengthen to make it, like I said, mandatory. I'm not sure it's mandatory. Now in Nigeria, we have the NHIS, which typically just covers 3%. I mean, as then I don't even know whether it's up to 3% now. It's not efficient in terms of the national health insurance scheme. But there is something that the current system have put in place, which for me was a promising development, and it rides on the National Health Act 2004. The National Health Act in Nigeria is saying that at least let's start the journey from the primary health care level, addressing the care required by vulnerable. We're talking about women and children. And they decided to make it a stepwise approach. If we focus on what defines our health, which is our health indices, the under 5 mortality rate and the mortality rate for women. This is what defines a country. And in Nigeria, that's why we are always behind, like just behind India or playing catch up at the behind. On the 5 mortality rate is very, very high. And which is why immunization is key. Yes, it's very, very high. Our women, the number of women that die in Nigeria every year, you know, we could say as at 2 years ago, every year we have 500 in let's say 10,000 women die. You understand? That's like the ratio, which is very high, and no country should accept that. So no matter what we do in infrastructure-wise, technology-wise, if women and children are dying, that's unacceptable, and that's what defines the wealth of a nation. Now, the current administration under President Buhari set in place what they call the Basic Healthcare Provision Fund, which is a kind of an insurance program that is going to provide free services for women and children, at least as a startup, as a national program driven by government. Now, government actually funded this, which is amazing. They set aside like 21 billion naira annually to make free services available for women and children. This was started like 3 years ago, but till date has not been implemented. Let me tell you why. Because again, like David has said, Kola has said, the strategy is wrong. Without strategy, you can't have money, but you can't use the money. Even with that basic healthcare provision fund, donors have said, like Bill and Melinda Gates set aside $75 million to say, because Nigeria government has brought out 21 billion naira annually, which is commendable for this program riding on an act. We will give you $75 million to strengthen that, and even World Bank made a commitment. How can we not implement? We can't implement because we don't have this strategy to assess these funds. When they actually, the Nigerian government called me and said, we have this money. 60% of it is to go into getting the right medicines available, 60% of the money. The rest is for infrastructure. Now, the challenge we're having is, if we buy these medicines, how can we get it to the health facilities? And I asked them a key question, and everybody has been saying supply chain. I said, how much of the budget is for supply chain? They said, we never budgeted for the supply chain. I said, I don't get. How do you set aside 60% of the money for commodities? You didn't think of the transportation, you didn't think of the warehousing. Well, what happened is the strategy was developed by medical personnel who are not like administrators, who, like again, Kola said, the talent required for strategizing, it's lacking. We need to think of best practices. So you can have mechanisms for financing. You can have an insurance program, but if the institution itself is not prepared to access the money, no bank will drop money. You can have it in paper. One of the things I think is going to happen, and I'll tell you why these things have been like this, because our government they haven't prioritized healthcare. They believe the priority, if you set up a budget, if you just put it there, but if you can't prioritize it to get it from policy to strategy to implementation plan to having the right people to drive it, to seeing it to the end. So what you have is so many initiatives, so many policies that never get implemented. So every time our government is launching one program, but one thing the COVID is going to do now is, because for the first time we are all locked in. Fantastic. Nobody can fly nowhere. And you see the chief of staff for Nigeria was ill. He came to Lagos to access care in a private health facility. Why didn't he go to the isolation centers defined by the public sector? Because for that reason, we're all going to sit back, like Ezine said, and we're going to think, this morning, yes, we need the right talent. We need to retain our talent. We need to leverage, and I very much agree with David. We don't have that capacity. We will not be able to develop that talent overnight. We can leverage the private sector. If you look at supply chain, Coca-Cola, we always use this example. In every village you go to in Nigeria, no matter the issue with power, you will get a cold Coca-Cola drink. Every village in Nigeria, if you go, you will get a cold, chilled. If you say, I need where are they getting it chilled? How can we not get vaccines in every village? If you go to your village, you can't dare go to the primary healthcare facility. So there is something private sector is doing in the same system, that the innovation is already there. We don't need to build the capacity in government because it's going to take time. We can start the process for sustainability, put in some strategies, long-term, mid, short-term. In the short term, we need to have a framework to leverage existing talent and innovation from the private sector. In the short term, in the midterm, we need to look at building capacity. We need to look at a framework to retain our talent. We have some of these talent, they are outside Nigeria. But just to, just to summarize, the money is there. The policy framework is there. But if our government does not sit down to prioritize healthcare, to see it from beginning to end, we are not going anywhere.
Thank you so much. I think Kola wanted to say something. Okay, you're mute.
I just want to quickly add that there is a sweet spot between a lot of the government insurance schemes. They come in at some very low prices, and so they do not have private health companies who can actually provide care sustainably at the sort of prices that the government has been able to come up with. So for us to get to a point where we will be able to get universal health insurance in Nigeria and in Africa, we need to build private institutions who are large enough, getting the right economies of scales, whether through PPE and whether through with some support from aid organizations who will not mind providing such like the $75 million that is sitting unutilized. If you have large private organizations who can sit in between the government scheme and the support that is coming from the aid agencies, they can be the ones who would help us provide that missing link. Otherwise, at the moment, a lot of the government insurance schemes would end up just being just what they are. At the moment, the NHIS in Nigeria is serving just about 3 million people, which is just roughly 2% of the population of the country.
All right, thank you so much. David, you want to say something? Okay, Ezine.
Hi.
Okay, go ahead. I can hear you.
I would just like to add from a bit of a different perspective. So I want to add from the perception of health insurance from a citizen. We have to realize that, I mean, there are a lot of great minds that understand how to implement health insurance. It's not a new concept. It's been done all over the world. But I want to take it from the citizen perspective. We have to realize that people have lost trust in the health system. And because of that, people are now geared to be more reactive about their care than proactive. Health insurance is encouraging people to be proactive, to save ahead of time. You don't wait till you need health care to actually invest in your health. Majority of the population categorize health below many things in their lives. So I know that from the conversations I've had with several people, and these are more citizens, most don't trust that if they pay upfront for the savings towards health insurance, that they're gonna get the type of care that they feel they should get. So the perception now becomes, I'll just hold on to my money until I need it. I'm feeling fine. Why am I gonna put money aside? And this is largely the mentality of many Africans. We don't believe that, you know, something will happen to us because it's not our portion. I hear this all the time. So while we're thinking about how to implement health insurance, we also have to think about the change in behavior and perception from the population that also has to contribute to health insurance. And then we still have to look at our care providers that have to deliver this care within the health insurance capitations. So I really feel, there's a lot of discussion that happen about health insurance, but if that family of 4 don't fully understand the benefits of health insurance, they're gonna be very reactive about their care, and it's usually when it is too late. And this is also a symptom of not having a proper care. Because if you have a proper primary care sector that actually works, and this is where telemedicine can actually truly enable primary health care, we will then really be able to educate and build that trust again in people to understand the need for health insurance. And so I just want us to also take it from that aspect when we're having this discussion, that more also needs to be done from the population perspective and the care provider perspective in order to have a very good health insurance scheme.
Okay, David.
You know, I'm glad you brought up, Zinni, that you brought up the idea of perceptions. This is critically important for PPPs as well, because if you want to get investors to invest in public healthcare through PPPs, you know, they are going to look at the situation in a country, and investors aren't sentimental. If there's a better deal somewhere else, they're going to go somewhere else. And the reality is that, you know, unfortunately, and I don't feel uncomfortable saying this because I'm an African myself, there are so many resources that have been wasted through corruption and misspending. And what is important is that we need to create a PPP procurement system, if governments are going to follow that way, where the procurement is transparent and it is competitive. And I'd say transparent because if it's not transparent, I think it's just going to go to the same 5 people all the time, and then they can escalate the prices and that. And why I say competitive is because you'll get a better value for money out of the deal, and you will also get a better deal when it comes to the technology, etc., that is being used. If you do not have competitive and transparent procurement for public-private partnerships in Africa, you are just going to be pedaling backwards.
All right, then. Thank you so much. So the last question for us now is to, think of solutions or recommendations, we think. And we've already made a number of recommendations already in our initial discussions, from telemedicine, to improving on having a strategy, as Azuka mentioned, that is very clear on how exactly is the private sector, going to take part in this. And covers also issues related to increasing human capital and what his firm is also doing on bridging that gap in itself. So just as a last word, before we round up in itself, what was your final thoughts on what's the way forward post-COVID? So let's say COVID, the whole 2020 is out of it. 2021, what do you expect, a governor or a minister or a president in an African country, what should be his strategy? What do you expect the president to be saying that, we're going to have a dedicated, national emergency response team focused on the healthcare initiatives in itself, or we're going to have a more donor, or increase our budgeting for healthcare and things. So I will start from Ezinne again, then move to Azuka, Paula, then I'll end with David before we just round up. Thank you.
Okay, thank you so much. I'm so sad this is already over. I was having such a great time. So I would say from a solution perspective, post-COVID year 2021, what I would suggest is, again, let's stick to the basics. Let's look at the people, the process, the technology. People-wise, we can use technology to upskill. We can use technology to enable teleclassrooms and invite all of our various healthcare experts all over the world to be able to transfer skills to the local health professionals on ground. This is not, we're doing it now. This can happen with training of nurses, health workers, doctors. People are doing telesurgery. And so again, from a people perspective, let us build our capacity using technology, because we can build the best health systems, but if we don't have people to actually deliver care, we're far out from when robots will start delivering care. But we can use technology to really build our human capacity. In terms of processes, we can definitely first look at what are the opportunities to really automate clinical workflows, clinical protocols, really being able to build that standardization. A nurse that practices in Lagos should be able to go to Abuja and expect to maintain the same standard of care. Technology can absolutely help us do this. And in also doing that, we can definitely create regulatory policies around it, so we can actually make healthcare more accountable for those practicing in healthcare. We can monitor, we can really evaluate quality and safety, and also cost containment. Technology can really help us do this, but those two things can happen with or without technology. And again, that is really the basics. Technology can now tie all of this together by providing more access to all of the various experts around the world to be able to supplement some gaps, especially around specialty services that may not be available in country. We're doing it now. We're linking specialists from across the world to doctors in Nigeria, and they're having great collaborative sessions, which otherwise would not be available to them. And that patient ultimately would be in jeopardy of dying. And so from a solution perspective, we have to keep it very simple. We have to keep it very localized. And again, people, process, technology. And I believe we're going to be seeing more of this post-COVID. Thank you.
Okay. Thank you so much. Over to you, Azuka.
Okay, so my recommendation will come in short term, what we can do now with what we have, and also in the midterm and long term. First thing for short term, we have 3 things that we must do. One is access that credit facility that CBN has put in place. We have 100 billion naira sitting in CBN, and we need infrastructure. We need test kits. We need states to access that. I tell people when they call me to say, I called NCDC, symptoms and NCDC. I said, you don't call NCDC when you have symptoms of COVID. You call the state call center, because it's the states that do the procurement and it's the states that have the isolation center. NCDC is a strategic platform that deals with policies and testing and research and all manner. So, that for me is very key, that states access that funds that government has put in place, because in that 100 billion naira is money for infrastructure, is money for pharmaceutical companies to quickly ramp up manufacturing. It's money for the healthcare providers that are going to be part of this. So I think I feel sad we have that money and yet we are not ramping up services. The second thing that is very short term that we need to do is exactly what Kola has said, and is inside that money too, is we need to find a way to increase our local manufacturing. We need to do something about having access to gloves, hand sanitizers, hand washing platforms, whatever we call it, and for the communities. So for me is the government as it is needs to do something about today, because we are still at the startup of COVID in Africa. What we see is we are seeing it rising. We're seeing it, and we're seeing it in communities. If you're watching the trend, you see that before in Nigeria, you see 10 cases, 20 cases. But as at 2 days ago, you see 70 something. We're going to see 100. And we see that in South Africa. Are we prepared for the surge? COVID needs us to make sure that we are able to reopen the economy, but we can't reopen the economy if we don't put structures in place. So that is also where I think advocacy comes in right now. Everybody should be an advocate. We should be telling our states to have a strategy to access grants, or a strategy to put in place to expedite procurement, also to make sure that we are managing the risks involved. Like we don't want so many things coming in that we can't account for. So everybody needs to there's that power in social media that has worked in Nigeria. Everybody must become an advocate, where we're saying to states, please have a strategy in place, please assess these services, and please make sure you are testing. So for me, that's short term. But in the midterm is what we've said. We need clearly defined strategies. We need to hold our government accountable, which is what we've been doing for ARC, is to advise government to prioritize public health care. You cannot say you are committed to primary health, to healthcare services if there's no money on the table. I recall having a meeting with the Minister of Health in Nigeria, who said, I want to improve warehouse. I said, do you have cash on the table? I don't want, I am committed in a statement in a newspaper. I want to know how much.
They call it audio money in Nigeria.
Yes, I want. I mean, like, we need to come to that level where we say, how much are we talking about, Mr. President? How much is it for healthcare? If we have our government, when you put money on the table, you will be committed. So we have to come to the point where our government put down money for public health care. That's where they will institute the insurance schemes. That's where they will be concerned about technology. But now, because they are leveraging donor support, do you know that, just to tidy this up, do you know that Africa, the global production for pharmaceuticals is just 3%. We rely 95% reliance on importing.
Wow.
Yes. Do you know that most of our services, most of our public health commodities, malaria commodities are coming from donors? One of the things we must do is to begin to push back some of these aids, push it back and get our government to take ownership. So some strong advocacy is a recommendation for government to take ownership, to put money on the table, and then we talk the strategy. So with this is strategy, advocacy for government financing, put money on the table, leverage private sector. Innovations are there. The people are there. Bring them back home. Then again is finally to say we are all advocates. We must speak. We must be very vocal about this, and everyone is an advocate. We have to bring in our voice in here. Thank you very much.
All right, thank you. So before we go to caller, and I just want to take a few comments that we have on our live stream, so that because we are rounding up soon, to just be nice to share. Olufemi says interesting conversation. John Adeli Soye says it seems like like needs analysis wasn't done prior to determine how the funds will be spent. So this is clearly okay. I mean, so he was talking basically about the various donors that made commitments to COVID, and maybe the COVID team must have done some needs, or so that the donors, know clearly what to give for and things. Septuga couldn't agree more with Asuka regarding low spending on healthcare, reactive responses in times of crisis. We also heard from Jenny, who agreed that the operational aspect needs to take priority, but the pipeline for skilled supply chain professionals working in public health needs to be invested in from an educational perspective. Yeah, I mean, it's really key, because I think it was I think Azuka or Kola was mentioning that even when you go get these ventilators, you go get these huge high-tech medical equipments, you still need people to man them, and that's really an important requirement in itself. Also hearing from Tope Ashami says that, finance hospital operations. What are your thoughts on how payer system models can make clinical care more accountable, like result-based models for quality patient care? And I think we've also addressed that when we're discussing on payer systems, basically looking at the fact that we need to, first of all, even have a national database of the various payers in or workers in the country, and looking at a model where we can target them to make a minimum. Even if you just pick the pension scheme that we already have, that could be a way where we can just as an additional payment to your pension, you need to make an additional 2 or 3 payments. And I think that will also be a better foundation for insurance commitments. Femi Ogunjobi says one thing that is missing is we are not developing homegrown solutions. It's either we are deploying capital to build sustainable healthcare systems that can harness talent or retain our doctors. That's also key. Someone mentioned that Izine's point about regulatory and policy alignment is quite critical. Nice submission, Izine. And I think, okay, there was someone here that mentioned that brilliant submission. There was this Uzo. Uzo said, I think healthcare should be seen as a national security issue. I think so too. If 80% of our manufacturing comes from Asian countries, then the day we have a diplomatic spat with them, we ourselves are put at risk. I agree too. And also, Chukwemeka mentioned that, well done, Azuka could not agree less. Our government have a misplaced priority at government budget for healthcare. It shows we are neglecting our greatest resource. And I think it's really critical for a number of things being mentioned here. But I believe that if we can get to the crux of the matter, I'm sure we will be able to solve these issues now that it has happened, and now that we are all locked in, as Azuka mentioned. So over to you, Kola, just to have your final thoughts before David, and we'll basically wrap this up. Mute.
Okay, many thanks, Femi. I think I'll summarize by saying that in the post-COVID world, we are going to see that healthcare is going to be somewhere between banking and national security. And that is really what COVID-19 has shown us. Banking is where we believe all of the world's assets, the monetary system, security and everything has really been decided. But we now quickly realize that our greatest asset, all of us, is actually our health and our lives. And if we're not putting the right system in place to make sure we have our health and our lives, we're not going to be there to even enjoy the money.
Yeah.
From a national security point of view, governments all over the world are maintaining large reserves of who can do guns or and do so many things in the name of national security. But we've all seen now that probably what we should have kept is barracks and large reserves of medical officers, who can be deployed when there is a pandemic. The way we define wars may totally change forever after COVID-19. All of this just points to the fact that healthcare is going to be where all governments will put much more priority going forward. You asked a question about what I would want the president of Nigeria to do if he has a chance to change healthcare from tomorrow after the COVID-19 response. We always work with an assumption that government is broke. The Nigerian government is broke. And honestly, and a lot of African governments too, from the debt service levels that are above 60% of revenues, look at the oil price now. You don't even expect the Nigerian government to have any money to spend. And when we even manage to allocate money, we already have systems in place that would ensure that such monies would end up being spent on trainings, overheads, ESTA codes, and other things, not actually on infrastructure or anything that would improve healthcare. So the government is going to wave a magic wand and do something. I would say that the National Health Act should actually be passed. There's an act that is meant to make sure that any employer of labor who has up to 3 staff should compulsorily buy health insurance for such staff. And this is possible. It's possible because as of 2000, Nigeria didn't even have a pension system. Today, we have more than 20 million people in the private pension scheme of the country. On the average, they are contributing maybe 20,000-30,000 to the pension schemes of these employees. Government mandating that all employers with at least 3 staff should buy insurance for their staff, it's not going to come out of government coffers. Rather, all these 20 million people who currently have pensions. So if we have 20 million people with pensions being paid, how come we have only 2 million people with health insurance? So with that kind of a law, we can definitely expand the pool of health insurance, expand the base significantly. And because they're going to buy this from private players, they will be properly priced. And automatically, the hospitals will then have a larger base of people. It would also contribute to changing the perception and behavioral trends where, like Ezine mentioned, where people typically to adopt a reactive rather than a proactive approach to their healthcare. When they're insured, they'll be more proactive. I would probably say this. The second thing that I think we need to do is that we're getting a lot of donor-funded money. 20% of healthcare spending in Africa comes from donor organizations. 20%, 1 out of 5. But a lot of this spending, in my own view, is not sustainable, and the proper needs analysis were not done before these monies were spent. And when you even go and look at it very closely, a lot of them, I think, still go back to the organizations or the economies that are providing the funding, because what they simply do is send a staff or buy equipment from their host countries and just ship those consumables or equipment or drugs to Nigeria or Africa, and then it's part of the donor amount, and you see this huge amount, but it's really not impacting the local economy. The way the industrialized world has negatively impacted healthcare the most in Nigeria and Africa is through the brain drain, where the best of our medical staff have actually gone to make sure to strengthen the healthcare system outside the country. I think the government of Nigeria can lead an effort to create a global fund that allows medical talents to come back and work in Nigeria. So you guarantee such talent a minimum amount of pay, and they just come back and work for healthcare organizations in Nigeria. And finally, for me, is I think the government should look at a supply chain and make an effort to tie industrialization to the medical consumable supply chain over the long term, and use that through a PPP model, encourage the private sector to target specific consumables, especially in the post-COVID world, where we all know now that a global supply chain is going to really be disrupted, is no longer going to be linear as it currently is. So those three things is probably what I would like to end. But I just want to also use the opportunity to respond to Okwe Ashimi's comment about how we can make clinical care tied to performance. And I think the current model of a lot of the national health insurance models are using, it's not going to work in the long run. A lot of private health insurance are also moving to the fee-for-service model, which is honestly also even encouraging abuse. In the long run, co-payment system. We think when consumers themselves have to pay, even if it's a token, 10% of their medical cost, that is going to be the long-term and most sustainable way to ensure that care providers are held accountable on one hand, and also the health insurance companies also know that they are really not being shortchanged, but as people tend to abuse in the country.
All right, thank you so much. Over to you, David. We have just 3 minutes left. Thank you.
I have a very short comment. What I've heard, and I think what we need to look at are for best practices that, really are pragmatic, that they break the way of doing business the old way, because if we keep on doing that, we're not moving forward. I think we also need to prepare for the next event. Everyone's talking about COVID-19, but what about COVID-21 or COVID-25? It's highly likely, if you listen to the doctors, that this is going to come back in some or other form. And this means that we have to, stop being apologetic about our failures and start embracing solutions that include, I think, resilient and sustainable practices. So I'll end there.
Thank you so much. Thank you, everyone, for the time. It's really been a good period to discuss. I wish we could have more time, but I think we'll spend an hour, 30 minutes now. So have a good day. And when we have more of this post-COVID-19 discussion series, we'll be able to still call you again to have more discussions. Thank you, and bye.
Bye.
Bye. Bye. Bye. Bye. Bye.